Now let's talk about left posterior fascicular block. As we know that, again, the left bundle is divided into the left anterior fascicle and the left posterior fascicle. Now, let's say there is a block in the left posterior fascicle. So the electricity will reach the left ventricle through the left anterior fascicle. If you look at the left anterior fascicle, it actually goes to the upper lateral wall of the heart of the left ventricle here. Okay, so when the electricity reaches there, the vector will be upward and lateral like this. A small electricity will start at this point. And again, we have the lateral leads, mainly lead 1 and AVL, and we have the inferior leads here, which are the AVF lead 2 and lead 3. Now, the electricity vector is going upward, so it's going toward the lateral leads and will give us a small R wave. In the same time, this electricity is going away from the inferior leads and it will give us a small Q wave. Okay, after that, the electricity now will spread to the full ventricle like this. And if you look at the amount of the electricity is going actually to the right. So you have to have right axis deviation. This is very important. Left posterior fascicular block cause right axis deviation. This is very important. Now, if you look at the electricity, the majority of this electricity is going actually downward and to the right. And this will produce a deep S wave and the lateral leads. And the electricity is going actually inferiorly down, and it will give us an R wave in the inferior leads like this. So the criteria is very simple. We will have small R small, deep S capital in the lateral leads, and we'll have the opposite in the inferior leads. We will have small Q wave with a large R in the inferior leads with right axis deviations. These are the triad for left posterior fascicular block. So again, we will have R small, S capital in the lateral leads, and we will have Q small, R capital in the inferior leads, and we will have right axis deviation. This is actually very important. Now, in cases of right axis deviation, multiple things can cause right axis deviation, right? So in left posterior fascicular block, the block should be 90 degrees or more. So you have to use the precise method to measure the heart axis. This is really very important because if you have a right axis deviation and you calculated the axis and it was like 80, okay, you say there is a right axis deviation, but not to the degree of left posterior fascicular block. So to have a degree of left posterior fascicular block, the axis should be more than 90, like 100, 110, whatever. And I will show you the diagram. And actually, the QRS complex would be, duration would be normal because it is incomplete block. It's only one of the fascicles that is blocked. Now, if you look here, this is the chart. And in order to have left posterior fascicular block, the right axis deviation should be here. Okay, it cannot be here. So it should be more than 90, And most of the cases, it will be more than actually 120 as well. Okay, this is very important. And the last thing, the left posterior fascicular block is diagnosis of exclusion. Whenever you have a right axis deviation, you have to exclude right ventricular hypertrophy and other causes of right axis deviation before calling this is a left posterior fascicular block. Okay, let's look at EKG here and let's see if we can diagnose the patient. Let's look at the axis. So lead 1 is negative, lead AVF is positive. So they are handshaking each other. So this is right axis deviation. If you want an accurate measurement, the most isoelectric lead is lead 1, as I believe. The perpendicular lead is AVF. AVF positive, so it goes with the lead. So it is positive 90. So it goes with a degree of left anterior fascicular block. Okay, so I have right axis deviation. If we look at the lateral leads, lead 1 and AVL, let's look at AVL. There is a small R wave with a deep S wave. So small R, capital S, this is in the lateral leads. And if you look at the inferior leads, 2, 3, AVF, you'll find the opposite. You will have a small Q first, small Q, okay, small Q here, and a large R. So Q, small R, capital, okay? And with these three things, you can diagnose left posterior fascicular block, of course, after excluding all other causes of right axis deviation. Now, this is very important actually. If you look at the leads here, the Kear's complex, sorry, is normal in duration. The Kear's complex is normal in duration, and this is also a suggestive feature of left posterior and even left anterior fascicular block. And thank you.